prevention and treatment among women and adolescents of childbearing potential, sero-positive for HIV, syphilis, and hepatitis B, their children and families. We'll give folk a few minutes to join, and then we will start the webinar. Thanks once again for joining our webinar today, which is going to review triple elimination, protege for integration. My name is Ruby Fayose. I'm the Deputy Director for the Clinical and Training Unit here at ICAP Columbia University. I'd like to welcome you all once again. I'm sure you're all familiar with the format of the webinar, but I'll just go over a few housekeeping issues. Please use the chat box if you have comments, and if you have questions for Dr. Newman, please use the Q&A function. The webinar recording and slides will be posted on the ICAP website by the close of day today or tomorrow. So it's really exciting to introduce our speaker for today, who is Dr. Morkor Newman Oredu. Morkor is a medical officer at WHO, leading the work on elimination of vertical transmission of HIV, syphilis, and hepatitis B, and women's health and HIV within the treatment and care team of the global HIV, hepatitis, and STI programs in WHO Geneva. She previously worked in the Africa Regional Office for WHO and has extensive experience in communicable disease prevention and control, HIV and STI programming, particularly elimination of vertical transmission of HIV in high-burden countries, as well as reproductive, maternal, neonatal, and child health programs. Morkor, the floor is yours.
Thank you so much, Ruby. And good morning, good afternoon, good evening to all. And first of all, I'd like to thank the organizers for the opportunity and also for all the participants for joining. This is a particularly important presentation for us. And we really would like to use the opportunity to express what our plans are in an area which is getting more and more critical. I hope you can see my screen.
Yes.
Thank you. So I'll get into it immediately. And just to start off by talking about this challenge which we are all familiar with, which is prevention of mother-to-child transmission or vertical transmission. It gives us an idea of the global challenge in that there's 1.3 million women and girls living with HIV. We have syphilis, almost 1 million women pregnant who were found to be pregnant, infected with syphilis in 2019. And also in 2019, there was 820,000 deaths attributable to hepatitis V. We'll go a little more into this as to why these are important. But then, if we look at the picture on the right, you see that we started off from 2010, 46%, and seem to be doing really well, increasing the coverage of treatments. But then now things seem to have been stagnated and are just hovering between 79 and 81 or 83. So there's work to be done if we really want to push things. Since the rollout of the highly effective and simplified interventions for lifelong ART, we found that virtual elimination of mother-to-child transmission has been shown to be feasible. Not only is it feasible, but we have strong commitments by our countries to promote integration of PMTCT into the maternal, newborn, child, and adolescent health service platform and strengthen our health system. Notably, this improves access to health, reproductive health services, and integration of interventions had led to what we call the Triple Elimination Initiative, which we will go into, which not only supports person-centered care, but also reduces incidence, morbidity, and mortality from infectious disease, while strengthening disease monitoring. So all this shows you basically what integration is doing for us. The focus of our presentation today will be on promoting integrated service delivery, scaling up prevention and treatment in sero-positive for all three conditions, and improving access to sexual and reproductive health. Just to remind us on integration, integrated health services are those which are managed and delivered so that people receive a continuum of health promotion, disease prevention, diagnosis, treatment, management, rehabilitation, and palliative care services. These must be coordinated across different levels or sites of care, not just within the health center, but beyond the health sector in accordance to their needs throughout the life course. It's a mouthful, but it's important. And we have the integrated person-centered health services framework, which promotes this. This requires a mindset change, buy-in, and it also addresses missed opportunities, how to catch up with existing executives. Another thing we're going to focus on today is that it requires agreement on how we measure progress. This is just a brief on the framework. It is available online. It calls for a fundamental shift in the way health services are funded, managed, and delivered. But basically, it's a vision of a future at which all people have access to health services that are provided in a way which is coordinated around their needs, respects their preferences, are safe, effective, timely, affordable, and of acceptable quality, which means equity in access, quality, responsiveness and participation, efficiency, and resilience. So the WHO Global Health Sector Strategies for HIV, viral hepatitis, and STIs for 2022 to 2030 have been noted with appreciation by the World Health Assembly, and it gives us the clear mandate to work with our member states on this framework until 2030. You note that this framework is guiding integration of services. That's why it's a joint and not the vertical three that we had previously. And within the MCH continuum, it helps towards triple elimination of mother-to-child transmission of these three conditions: HIV, syphilis, and hepatitis B. These are the ones which are important because these can be transmitted to infants or fetuses during pregnancy or breastfeeding. What do we focus on? Putting people at the center. Also, the national planning of efforts should be guided by these health sector strategies. We have new priorities for each disease areas, but a shared approach towards strengthening the health and community systems. It helps respond swiftly to changing health and development contexts, focuses on eliminating stigma and discrimination and other structural barriers. These can be demonstrated by the shared global targets that we have. This is just a picture of the framework, and please note that we have a common vision to end epidemics and advance universal health coverage, primary health care, and health security. There are these specific goals, which are indicated here, but we note that we have shared strategic directions, and there are 5 of them: delivery of high-quality, evidence-based, people-centered services, optimizing systems, sectors, and partners for impact, generating and use data to drive decisions, engaging empowered communities and civil society, and last, fostering innovations for impact. The drivers of progress, which we shouldn't forget, are gender, equity and human rights, financing, leadership, and partnerships. In improving access to SRH, we must remember our definition of how different kinds of sexual and reproductive health and HIV services can be connected together to improve the health outcomes of the people served. Only 3 of the tools are demonstrated down here. Probably the most familiar one will be the rapid assessment tool. And then we have the providing contraceptive services in the context of HIV programs. And then another tool which shows us clearly how integrated services can be carried out related to the SDGs, which are shown on the right. There are several other tools, but these are all available online to support improving access. So now to come to triple elimination. We will talk about elimination of mother-child or vertical transmission. We'll talk about the old and the new. We'll have a bit of a discussion on how we get to triple elimination with integration and how we know when we get there. As a background, if you remember, as far back as 2002, the UN promoted the 4-pronged strategy. And it's amazing that we are still using it now. And we really have to do something about that. It was developed prior to widespread implementation of the Treat All strategy. It did not include interventions for syphilis or hepatitis B virus, and the testing services were not included as a prong, but as an essential and overarching service that provide to initiate the provision of PMTCT of HIV at the time interventions. So we had 4 prongs, which we have illustrated here. Prevention of HIV among women of reproductive age within health services related to reproductive health, such as antenatal care, postpartum, and so on, and including working with community structures. The second prong was providing appropriate counseling and support and contraceptives to women living with HIV. So if you remember, this really focused on the unmet needs for family planning and spaces of birth, and to optimize the health outcomes for women and their children. The third was access for pregnant women living with HIV to ensure they were tested and counseled and had the needed antiretroviral drugs to prevent infection. At this time, it could be treatment if the woman needed it, or prophylaxis. And this stopped the passing on of the virus to their babies during pregnancy, delivery, and breastfeeding, while HIV care and treatment support for women and their families was the 4th prong. So as we've been going now, we've combined 3 and 4 without saying much about it. A reminder, our commitments. We have committed to EMTCT since 2014. Now, we renewed this gave us a renewed focus to end the epidemics of HIV, hepatitis, and syphilis by 2030. It also revitalized global interest in addressing maternal newborn child health issues, which is also buttressed by the United Nations Secretary General Global Strategy on Women's, Children's, and Adolescent Health. And we are determined to dedicate significant resources and attention to achievement, noting that this is a high bar, but we have shown good progress. For instance, if you look at this graph, there's so much green because many countries have a national plan for elimination of vertical transmission of HIV and syphilis. And this was in July 2022. Triple elimination, the protege, and let's go into a bit into what a protege is. We'd like to say it is our star charge for integration. French translation of protege is to protect, but we're dealing more with the English translation. And English is a person who is guided and supported by an older, more experienced or influential person, or a person who receives special protection and promotion from someone established in that field. But rather than this being a person, It is a program which is PMTCT or EMTCT. So our responsibility as community of stakeholders for guaranteeing integration and achieving triple elimination of mother-to-child transmission or vertical transmission of HIV, syphilis, and hepatitis B. This is our responsibility as a community. Our focus should be on people-centered care. And this is because pregnant and breastfeeding women need differentiated models of care that respect their evolving needs, ensures availability of quality, routine maternal care, primary prevention, scaling up of treatments, and prioritizing the integration of SRH by increasing access to and uptake of services. And these include family planning, STI prevention and control, addressing our adolescent girls and young women in adolescent health, also addressing RMNCH in key and vulnerable populations, because these are very often the drivers of epidemics, and very importantly, civil society engagement. Currently, what is our thinking? The rationale for triple elimination is that all three infections are transmitted sexually and vertically. They are often silent with long latency periods, and infected mothers are often unaware or have no symptoms. These three conditions can cause significant maternal and child morbidity and mortality. However, all three can be identified during our antenatal care and treated to prevent vertical transmission. So, how do we get there? We have proposed pillars, and this is still under discussion. So this is not the final, but just to say that we have proposed pillars for facilitating integrated service delivery within the reproductive, maternal, neonatal, child, and adolescent health program or platform for triple elimination. So in place of the first prong, we now say prevention of, and all the ones in brown are the new additions, in white fonts as the old. So prevention of HIV, and we add on syphilis and hepatitis B infection in women and girls, because we need to focus very much on the services for adolescents and young women of childbearing age within health service. Now, for prong B, instead of just providing the family planning, we're now looking at providing sexual and reproductive health care to women and girls living with HIV and hepatitis B, or providing linkages to SRH services to meet the unmet needs for family planning and spaces of birth, which is from the original, and for management and control of STIs. And all this because it's better to have a wider approach which looks at SRH, and that fosters integration all towards EMTCT or triple elimination. The third prong would be appropriate maternal treatment for pregnant and breastfeeding women for the prevention of transmission of HIV, syphilis, and hepatitis B. This will be based on treat all for HIV, syphilis treatment, and then hepatitis B virus treatment where eligible, noting that beyond prevention of transmission to infants, some women and girls will require treatment from their own health. Noting also that this is work in progress, and there is an ongoing review of the interim guidance on treatment in pregnancy and for reducing transmission for children, noting that the transmission is not just from the mother, but horizontal with other children while they are in their young age. The next is the treatment and care and support for the infants, infected children, and partners of the index patients. So this is where the family comes in. Testing for the infant is here. What's new is immunization for hepatitis B, and then appropriate prophylaxis for infants, appropriate treatment and care for both HIV and syphilis infected infants, because we note that in many programs, the treatment for infected syphilis infants is not clearly spelled out or practiced. then partner services for all three conditions. Lastly, mainstreaming of testing services. And this is because testing services occur at all stages. And that is what decides whether a woman goes into care for someone living with HIV or preventive care to ensure they do not get infected with HIV. It's at all levels. It consists of counseling, and this is the testing services. There's counseling, there's linkage depending on the test result, appropriate prevention, and coordination with laboratory services to support quality and delivery of correct response. So mainstreaming testing, an example we have right now is the adoption of the dual rapid diagnostic testing in ANC as A1, the first test. You can see here in green, it's the countries who have adopted for both pregnant women and key populations. And then in gray or white, where there's no data reported or not applicable. So we are moving, at least the policy exists in many countries, and this is pushing integration of syphilis and hepatitis. Now, the last bit, which is requires the agreement on how we measure it, we'll go a little bit into that because we need to know when we are there, if we really want to be able to say that integration has helped triple elimination and we are achieving what we have planned. That's where validation comes in. Validation is how we measure or how we know when we are there. Validation is just to confirm or attest that a country has successfully met the criteria of elimination as a public health problem. And in this case, it's EMTCT. It's an independent process to confirm that the standard criteria, which we will go into, have been met. These criteria are impact, programmatic, and then also for supporting and enabling services, functions, and policies. So far, 16 member states have been validated and they are listed here. The most recent was Oman in 2022. And one, Botswana, has been validated as being on the path to elimination. This is probably the most important because it helps countries who are not there to move progressively towards validation, even if we know we're not going to get it just at this time. So Botswana was the first country, and we have many other countries who are particularly interested, even when they are not quite there, to see how best to move in that direction. So these are the criteria, which I'm sure most of you are familiar with: mother-to-child transmission rate in HIV, and then case rates in both HIV and syphilis of 50 per 100,000 live births. And these are the impact criteria. It's a little different for hepatitis B, where we use the prevalence of hepatitis B surface antigen in less than 5-year-olds. And this is because this is a proxy indicator for how much transmission has been happening in that age group. Now, for the process criteria, antenatal coverage, testing coverage, treatment coverage for HIV and syphilis, but for the hepatitis, the most effective intervention is immunization. So depending on whether a country has universal birth dose or targeted birth dose, there are indicators which have to be met. First, the B3 penta vaccine coverage, and then the hepatitis birth dose. Now, if the country does not do universal birth dose, they also need to have a high coverage of maternal testing, because it's only then that you'll be able to identify those who are infected for targeted interventions. Path to elimination is illustrated here. As we said, you go from bronze to silver to gold. It's the same process and tools, but the impact criteria, the infant case rate is different. Instead of being 50, it ranges from 250 to 750. But the antenatal testing and treatment is 90% and advancing to 95%. For the path to elimination, it is different because it's based on immunization, and we are looking at vaccine coverage, whether the data is available, what the values are, whether universal dose is policy and practice, And then we have the bronze, silver, and gold, depending on where we are with these indicators. But there are no impact criteria for gold, silver, or bronze. The countries who are eligible for Part 2 elimination are those with a high HIV seroprevalence more than 2%, syphilis maternal seroprevalence more than 1%, and for hepatitis B, the prevalence in 5-year-olds of 1%, or in the general population of more than 5%. This just gives a schema of what it looks like when we put all three together, and you have the slide, so you'll be able to see. This is also available in the documents that gives the standard processes and criteria. We also need to look at programs and services, laboratory services, surveillance and data evaluation, and then human rights. All these are essential for integration. We need to look at both public and private and make sure that the services are available and accessible, acceptable, affordable, quality assurance for the lab. And then for the surveillance, the system must capture both public and private data on service delivery and outcomes. Lastly, human rights, gender and community engagement are extremely important when we are looking for whether the services have been implemented in a manner which is based on human rights principles and gender equality with a supportive legal environment. These are the standard tools and structures which are used. The three main documents, but all the tools are online. Many are being revised, and by June, we should have the new ones online, because you can see that many of these are focused on just HIV and syphilis, and there's a need for us to include hepatitis, which we're in the process of doing. Other programmatic indicators, and we're looking at the MCH information system. It should be able to monitor incidence, seropositivity, viral load, initiation of antenatal care early, family planning, and teenage pregnancy rates. These are clear things which cannot be done in a vertical program and must be integrated so we can be able to access this information. In addition, the program should monitor follow-up care and treatment of infants who are born of HIV, syphilis, or hepatitis B seropositive women. Just as a matter of interest, this shows us our countries who are getting close to the pathway, and this is from data 2021 from UNAIDS. You'll find that those who would fit in the elimination validation are those below the blue line. In our region, in the African region, most of our countries are generalized epidemics, so are more likely to be able to, and fairly high burden between gold, silver, and bronze. And you can see Botswana here. Like we said, they were recently validated as being in silver. South Africa doing quite well. However, because the mother-to-child transmission rate is less than 5%, but the case rates are higher, they don't fit in here. Namibia not doing badly. Lesotho is outside the 5%, which means they have a mother-to-child transmission rate which is higher than 5%, and so cannot be considered at this time for validation. But it's important that the indicators are followed and that the information is used to plan improvements so we can get to validation. You find that there are many African countries who are within this region. The countries with very low prevalence have a much higher chance of achieving the elimination case rate of less than 50 per 100,000 live births. This is global, so it also gives you an idea, and you can see that there are countries like Thailand who are even less than the 2%, but they are breastfeeding, so they need to be less than that. But then many of the countries shown here still have rates which are more than the 5% cutoff. So first step to apply for validation is that we should meet the impact and process targets and demonstrate appropriate policies and systems are in place. and the country should do a checklist, which is a preliminary draft self-assessment. This self-assessment, even if the country is not ready to apply for validation, gives a clear picture of where gaps are and where corrections can be made so the country progresses towards elimination. This draft can be reviewed, and then the objectives of this are to work within the planning stage, like we said, to jumpstart the process. And it provides a comprehensive overview of the EMTCT program. It simplifies the process of completing tools, and like we said, provides the opportunity to identify potential gaps and areas, and highlights key data and programmatic issues which need to be addressed if a country is to get to elimination, or even just get to the 2030 goals of the global health sector strategies that we spoke about. It's important to start these processes early, even the country indicators have not reached the validation requirements. And the Triple Elimination Initiative provides the framework for moving from single to dual to triple elimination. We also have the last mile framework, which was led by UNICEF, which assists higher burden countries to really sharpen their programs and ultimately drive towards the elimination goal. The key steps are listed here. We don't need to go through them, but experiences from the field we find are particularly important. Like we said, the process needs to start early, even if a country has not reached the indicator validation requirements. The human rights issues keep coming up, and the engagement of the community must be from the start of the process and must be meaningful. We need adequate surveillance systems in place, laboratory quality assurance, and both public and private delivery should be included in the assessment. The assessment of marginalized populations, such as migrants, immigrants, and persons in the lowest performing subunits, is critical to show where we really need to put more effort into addressing the drivers of the epidemic. The opportunities we get right now are from, for instance, the Global Fund Program Essential. This information note now has a whole section 3.2.4 on eliminating vertical transmission of all three conditions. This opportunity really gives us the impetus to request for funding which will support interventions to get to elimination, including integration. So if you look here, you can see that we're looking at integrated HIV testing and rapid initiation. We're looking at treatment continuity, prevention of new infections, infant prophylaxis, early infant diagnosis and follow-up, and also integrated service delivery with SRH and MNCH in mind. Another opportunity is from the Global Alliance to End AIDS in Children, which is a new commitment. And it's important that we have our interventions aligned around the 4 pillars: early testing and optimized comprehensive high-quality treatment and care, closing the treatment gap, like we've shown you we have stagnated, and then preventing and detecting new infections among pregnant and breastfeeding adolescents and women. Because we find that in many of the high burden countries, these incident infections are missed and also often are the source of new infant infections. And lastly, we need to address rights, gender equality, and the social and structural barriers that hinder services. So in conclusion, to get to triple elimination, we must promote integration and scale up prevention and treatment, as well as increase access to SRH services. Triple elimination is feasible, and it's facilitated by people-centeredness, which is driven by integration. And this integration must be well planned and well coordinated and monitored, so we know where we're going and when we get there. And triple elimination, lastly, should be nurtured as the protege for integration. So this is just to make the case for integration and triple elimination. And I'd like to acknowledge colleagues in the two departments who really are driving triple elimination. Thank you.
Thank you very much, Morkor, for that excellent presentation. Please, I'll encourage participants to put their questions into the Q&A box so I can share them with Dr. Newman. So Morkor, I have a few questions I'll start off with, and then I'm sure participants will put in their questions in the Q&A box. But you've talked about the importance of lab QI, and I'm just curious, does WHO have any sense of coverage for hepatitis B testing? Because currently there is the dual HIV syphilis test, which most programs are using. I know in some countries there have been issues with stockouts, but can you comment about the availability of hepatitis B testing to support this work?
Thank you very much, Ruby. I think you've brought up an extremely important point. You know, we've been pushing for the dual test for a while, and we actually have pre-qualified dual test. So WHO Global Fund would promote and fund these test kits. And the advantage is that HIV testing, for instance, has always been high, and syphilis testing has fallen through the cracks. So this integration pulls up syphilis testing to the level of HIV. When it comes to hepatitis, it's still new. We're still in the process of getting all our lab requirements right for hepatitis testing. As we speak, we do not have a pre-qualified test, which is for all three conditions. Some countries have been considering that, but we are going through the process now, and we do not have, like we said, a pre-qualified test, but are encouraging countries as much as possible to look into getting what is available already into their systems so that women can be tested for hepatitis as well. There are many countries who have been doing the testing, but unfortunately didn't have treatment programs. So it was like testing was a bit in vain. But now countries are getting their hepatitis treatment programs together, and a lot of support is provided from WHO and other partners. We are considering, and as soon as we have something which is pre-qualified, we will promote that.
Thank you. So there are two questions in. The first one is from Nandita, and she's asking, is there an opportunity to make sure elimination validation includes maternal to child transmission rates at the end of breastfeeding? HIV-exposed infants' final outcomes is often very challenging, but it's critical to pay attention to. So are they looking at the vertical transmission rates at the end of breastfeeding?
Thanks again for that question, Nandita. At the moment, we are fortunate that that information is used by UNAIDS when they're doing the estimations or the spectrum estimates for mother to child transmission rates in different countries. What is unfortunate is that we do not have enough data coming out from countries, so that makes that challenging. But that source or that use of that information is really important and will become more important as countries provide it rather than us using default values. Also within the criteria and processes, we do have other indicators. I did speak about some of them in the other programmatic indicators in the presentation, where we look at the early initiation, family planning, teenage pregnancy, and so forth. And one of those is also the early infant diagnosis at this time. We will include final outcome because we recognize that it is very important, And we have had countries requesting that that information is included in the criteria which will be used. But then we still are waiting for more robust information before we start insisting that all countries should put this in their validation data. It is welcome, and if available, should be provided, because the whole picture is needed when you are looking at validation. The whole picture of the whole program in a country is needed. Thanks.
Thank you. There's another question from Dr. Franklin from Nigeria. His question is, he says, due to low syphilis positivity, most countries are not motivated to procure treatment commodities for syphilis. Is there any plan to provide treatment drugs for syphilis for mothers and infants?
Thanks again for that question. The low positivity has always been an issue which we try to raise, because even when we have low positivity of HIV, we do test for HIV and treat HIV. Syphilis is unfortunate in that it is an old disease. It's not very exciting, it's not very sexy. And we have many programs where the syphilis has fallen through the cracks. So the treatment, which is still benzathine penicillin, which is still cheap, still can be bought by governments, is not prioritized and is lost. So we would say that Global Fund is not necessarily funding these things unless they are, you can really, really justify them. But it's more important for countries to prioritize in their plans and maybe use other funding to get the treatment. Our issues with the treatment is even where it's being given, it's not recorded, so it doesn't appear to be given at all, because what gets reported is what is done. But we know that having the dual test has really supported the syphilis program and has made it a bigger priority than it was before. But the procurement remains a challenge. And in some countries, there are even stockouts, but it's because of the prioritization of syphilis drugs rather than that the availability.
Thank you. So there's a comment which kind of follows up on Franklin's question, and then there's a question after that. So ARVs and rapid test kits are sometimes more available compared to essential meds such as penicillin because of siloed supply chains. How can programs ensure that all commodities for triple elimination will be available in an integrated service delivery setting?
Thanks again for that question. And this is why we keep pushing integration. Now, if you look at integration, it's looking at using each other's resources, whether it's funding, whether it's human resource, whether it's just the infrastructure which is available, like the labs. We need to have integration in such a way that we don't have these siloed approaches where there's funding for one thing and that's the only thing which gets done. It is true that, for instance, the Global Fund is for AIDS, TB, and malaria. So it's difficult to get Global Fund sometimes to do diseases outside this. But we must admit that where the infections, where a woman has both infections, sometimes HIV and hepatitis, we can use funding to support the whole woman as an integrated person-centered approach, rather than just have these siloed approaches. I think it's similar also for PEPFAR funding. We need to be creative. We need to make sure that the way we push our programs forces integration, both of the program implementation and the funding or the prioritization of these. If we go the triple elimination way and insist that we are going triple, we are more likely to have support where the three programs are supporting each other rather than just one, HIV, being funded and the rest not.
Thank you very much. So Irene had asked earlier on, one of the key challenges is the availability of STI test kits. And I know that you talked about integration of sexual and reproductive health is really key in treating all STIs. There is the use of the syndromic management, which is not the best approach to treatment of STIs. So can you comment in terms of availability of test kits for identifying other STIs? Is this something that is going to be made available?
Thanks again for that question. And this is really a serious problem. STI does not have many investors or stakeholders or enough people willing to really put resources into the program. And that's why we try as much as possible to have this integrated approach. And granted, it's not always very easy. We do have a program which is looking at multiplex testing, and we have a few consultations which have been had on seeing how these different multiple platforms can be used to promote each other, more or less. So you find that we have, for instance, currently we have the dual test, which helps. But then we are hoping, for instance, and if you look at the typical example being the viral load machine, you find that we're using it not just for viral load and HIV, but we're using it for other things so that this infrastructure is there, but then the other program more or less has to buy its own cartridges. These are the beginnings of working together. We still know that it's difficult to get funding, and we need to get our governments to prioritize these other STIs. We have had World Health Assemblies where these have been considered. For instance, recently, it was looked at STIs as far as them really causing infertility. And that was a big problem which was brought up at one of the World Health Assemblies. We know that these things are priorities, but it's important for our member states to recognize these as priorities, and then we can advocate better for the drugs or the test kits that we need if we really want to get these STIs down. But the STI program, like we said, has fallen through the cracks. And there's an urgent need for us to raise the priority of STI programs. Who would believe that congenital syphilis would be going up in developed countries? And it is. And it's because of the deprioritization of STIs. But let's all be advocates for this and make sure that we integrate so that all the resources can be used for the STIs, HIV, and hepatitis at the same time. Thanks.
There's another question from Miesa. He says, thank you, great presentation. Could you please elaborate a bit on the M&E platform required for triple elimination, especially for countries where PMTCT data is not well captured electronically, for example, data for congenital syphilis?
Thanks again for that question. So often congenital syphilis interventions are carried out, but data is neither collected nor reported. Yes, we keep saying that the integration needs a standard strategic information system where we have the electronic system. Currently, we have many countries who have electronic systems for HIV, but do not have it for the other diseases. We are slowly moving towards that. There are times when it's HIV which is prioritized because that's where the funding comes from. But if you look, for instance, at the DHIS is a system which other programs can invest in, as well as the HIV program, to strengthen it. And then that system will be available to collect information across all diseases rather than just having a vertical approach. So I think it's up to us when we are integrating to look at all parts of this wheel. And that means it's not just and one of the things, if you note, one of the things that we talked about in the global health sector strategies is information for action. We need to invest in these areas, but not to do it with tunnel vision, to invest in such a way that it's going to serve all the conditions and not just HIV, which has been happening for some time. And very often, if these things are justified for global fund, that's why the RSSH module came into place. If these things are justified for funding, they do get funded. And countries really need to strengthen the whole system and not just the vertical HIV data system.
Thank you. Anne from Kenya is asking if you know of any countries that have been validated or those on the path to validation have used an electronic medical record system for monitoring their mother-infant pairs along the elimination cascade. And are you able to share these so that countries don't need to reinvent?
Right off the top of my head, I know that there's some funds, I think Zambia has an electronic system. I think Uganda, I'm not very sure, but many countries have the electronic system for HIV, and it's a matter of getting them to monitor PMTCT, triple elimination, and not just HIV. This will require some planning, some negotiation, some investment. But these are possible when we have the right people in the room when these discussions are being made. We find that very often the EMTCT focal points or even the RMNCH focal points are not present when these discussions are being held, be it a global fund, be it an investment in an electronic system. We need to be there at the table to advocate for PMTCT data to be included. And one of the ways for pushing this is going for elimination validation. Even when you are not ready, you have these gaps identified and you make noise, and these things get funded.
Thank you. So Joseph is taking us back to the question around the gaps in investment in STIs. And he's asking, what are your thoughts around highlighting the gaps in STI vis-a-vis the emergence of antimicrobial resistance as a major global health burden? Right. How can this issue be tackled?
Thanks again. Now, antimicrobial resistance is gaining more and more traction now as we speak. We focused very much on HIV drug resistance in our unit, but now have really accepted that we have to have HIV, STI, and hepatitis drug resistance being looked at together as part of AMR. We recognize the HIV drug resistance program has gone much further than the rest and are now setting up systems to do the STI drug resistance. We know gonorrhea, for instance, has been going on for a while, and the actually is a separate department in WHO that looks at that, but we are working closer together now. It all boils down to investment. The interest is there, it's coming up, it's getting more, but we haven't quite gotten there. But I'm glad that you asked the question, because these are the things which push us to move faster and really get things done. AMR is a problem. Syndromic management will continue, but then even syndromic management does have some things which are supposed to be done, like surveys to look and see whether these drugs are still working or resistance is developing, and not many of our countries are doing that. So the drug resistance problem needs to be addressed. And we hope that if countries show enough interest, we'll be able to push this.
Thank you. Felix is asking that how are we going to ensure male engagement in triple elimination? We know it's been a challenge even in HIV. And so now that we are talking about triple elimination and engaging males, how are we going to do this? Any suggestions?
Very important point. And this is one of the reasons why we emphasize that we need to look at treatment, care, and support for exposed infants, infected children, and partners of the index patients. This cannot be done without male involvement. The male involvement is critical. It has been a gap which has been identified and not adequately addressed. And that's why in many of these, we continue stressing on the involvement of community systems, which will involve men. We recognize this gap. We are not doing enough, but we hope that with the new pillars and the integrated service delivery, which spells out partner areas, we should be able to address males better.
Thank you. I think we'll go to the last question. And this is from Subari, who's asking about treatment for newborns with congenital syphilis. The definitive drug of choice, which I know is penicillin. I guess this should be on the essential medical drug list.
Yes.
And she's also asking if there's data on stillbirths, which is a major obvious outcome from mothers who have syphilis during pregnancy. Are there any specific recommendations you would give to improve treatment for these infants born with congenital syphilis?
Yes, thank you very much. The adverse birth outcomes are currently being estimated because we don't have enough syphilis data. I think the onus is on many of us to see what it is we can do to ensure that syphilis data gets prioritized. This is available in many of our midwives' monthly returns, but not always moving up to where the data is used. We also have the fact that the syphilis estimations as they are, we have a congenital syphilis estimation tool, which helps countries to know where they are and hopefully helps them to plan better. Now, when it comes to how to get syphilis really, congenital syphilis really prioritized, it's funny, since 2007, we have had an elimination of congenital syphilis strategic plan, and yet we haven't gotten anywhere with this. We are still struggling. We need to prioritize syphilis. The treatment of exposed infants is either not in guidelines or not available to midwives or those who have care of neonates. So we find that in countries, not only are they not doing anything, they're not reporting anything. And this is a huge gap which needs to be addressed. We hope that with the increasing interest in congenital syphilis, because it's going up, we shall be able to get countries to put this in their guidelines and make it available to the healthcare providers at the lowest level so that they are able to really take care of these infants. And you are right, the drug of choice is still benzathine penicillin.
Thank you very much, Morkor. We're at the top of the hour. The webinar recording and slides will be posted on the ICAP website. This should be available by the end of the day or tomorrow. Our next Grand Rounds webinar is on Tuesday, March 21st at 9 a.m. Eastern Time. The topic is bridging the gap using mathematical models to monitor the HIV epidemic, and it will be presented by a panelist. I'd like to say thank you once again to Morkor for that eloquent presentation on elimination of HIV, hepatitis B, and syphilis. And thanks to our participants for the dynamic questions. Have a good rest of your day. Bye.
Thank you.